Obstetrics is a really unique and special field. There's no other branch of medicine where you're dealing with not one, but two physiologies that are linked. Partly because of this, and partly because doctors love acronyms, the field of obstetrics has a lot of its own terminology. We'll review some of the basics in this video, as these are all terms that will come up every day while on labor and delivery. Since we're going back to the basics, let's take it back, like all the way back. To kindergarten, that is. Just when you thought you were a graduate student becoming a doctor, it's back to those ABCs. Or should we say G's and P's? But we're getting ahead of ourselves already. Oh wait, the school bell's ringing. Time for class. First off, we gotta make sure that the patient is actually pregnant. For that, we test for beta human chorionic gonadotropin, or beta-HCG. Beta-HCG is a hormone that's initially produced by the placenta in order to support the corpus luteum to continue to make progesterone. Both urine and blood pregnancy tests detect beta-HCG. The urine test is a qualitative, positive or negative beta-HCG test, and the blood test is usually a quantitative, amount of beta-HCG detected test. If it's a quantitative test, the level of beta-HCG should double every 48 hours and peak at about 10 weeks into the pregnancy. Another way to diagnose pregnancy, and something that's used as an adjunct to urine or serum testing, is ultrasound. With a transvaginal ultrasound, an intrauterine gestational sac should be able to be visualized at 5 weeks. By 6 weeks, a transvaginal ultrasound should be able to see a fetal heart rate. Once you've established a pregnancy, the next step is to date it. This is the most important step of diagnosing a pregnancy for many reasons. Calculating the gestational age and estimated due date will determine the time course for the rest of the pregnancy, and most importantly, when the baby will be delivered. Also, most of the terms you'll hear depend on the gestational age of the pregnancy. There are multiple ways to determine these. The two main ways are by last menstrual period or by ultrasound, and in practice, both are used in tandem to obtain the most accurate gestational age. If the patient meets 3 criteria, you can use the first day of their last menstrual period as a dating tool. The 3 criteria are that they have a regular period, approximately every 28 days, that they remember the first day of their last menstrual period, which we'll from now on refer to as the LMP, and that their last period was a normal cycle. If all of this is true, you can use something known as Naegele's rule to calculate the estimated date of delivery, or EDD. This is done by counting back 3 months from the LMP and then adding 7 days and adding 1 year. This is on average 280 days from the first day of the LMP, which corresponds to 40 weeks. So remember, when you're talking about someone's due date, that's the day the fetus will be 40 weeks. If the patient does not qualify for an EDD by Naegele's rule, or to confirm the dating based on their LMP, you can use ultrasound to date the pregnancy. The earlier in the pregnancy the ultrasound, the more accurate it is. So ultrasounds done in the first trimester are the most accurate. We've arranged these 3 windows so that the one all the way on the left represents the first trimester, the second represents the second trimester, and the third. Like we just mentioned, the first trimester window is the best place to get a dating ultrasound. You do this by measuring the crown rump length, and then your fancy schmancy ultrasound machine will let you know how many weeks and days the fetus is measuring. Crown rump is exactly what it sounds like. A measurement from head to butt. A very rough way to estimate the number of weeks a fetus is, if you don't have any other method, is to measure the length from the pubic symphysis to the palpable top of the fundus in centimeters. A general reference point is the umbilicus, which corresponds to about 20 weeks gestational age. This method is extremely limited and doesn't work if it's a multiple gestation pregnancy, the body habitus limits palpation of the fundus, the patient's uterus is distorted by fibroids, or if there's any fetal growth or amniotic fluid disorders. In reality, you wouldn't use this method to date a pregnancy unless someone came in with nothing and was delivering immediately. However, we mention it here because when you go in to see patients for their prenatal visits, you're going to see a long measuring tape on the table, and this is what you use it for. The fundal height is mostly used for roughly tracking fetal growth between formal ultrasounds. If there's a discrepancy between the stated gestational age and the fundal height, there may be a growth disorder occurring, which we'll review more in another sketch. Okay, now that we've got assigning a gestational age down pat, on to all those numbers and G's and P's and trimesters and terms that you've heard being thrown around. You may notice that next to each patient, either on the L&D board or in a question stem, are the letters G and P followed by a bunch of numbers. For example, a 27-year-old G3P2103 comes into OB triage. Let's break down what each of these letters and numbers mean. The G stands for gravidity, and the number that follows is the number of times the patient has been pregnant. So far, pretty easy. P stands for parity, and this is where it gets a little more confusing, because as you can see, there are 4 numbers after the P. Remember the acronym TPAL. This stands for term, preterm, abortion, and living. We're going to represent each of these letters with one of the 4 little birds down here. T stands for term, and the number it represents is the number of pregnancies that were delivered at 37 weeks or greater. We're representing the T in TPAL with this bigger 37-week hatching egg. P is preterm, and it stands for the number of deliveries from 20 weeks and 0 days to 36 weeks and 6 days. P is represented with the second, littler hatching egg. A stands for abortion, symbolized as this third unhatched egg, which means any pregnancy losses, voluntary or involuntary, prior to 20 weeks. This includes ectopic pregnancies. L stands for living, represented by this living baby bird, and it reflects the number of living children that the patient has at the time of your interview. These numbers get a little tricky when dealing with multiples, such as twins or triplets. In these cases, G is still 1. This is because even though they had 2 kids, they were just pregnant once. The numbers representing term, preterm, and abortion would also count per pregnancy, so you wouldn't add 2 into the term number even if you delivered twins. Living is the only category that would count multiples as individuals. So if a patient had 1 term twin pregnancy with 2 living babies, their G's and P's would be G1P1002. While the TPAL terminology splits term, preterm, and abortion into 3 separate categories, there are actually many more subdivisions that are used for management decisions. This is because with each week or even day that passes, major changes happen in the fetus. The practice of obstetrics is always about weighing the risks and benefits of more time in the womb to develop versus delivering and having development happen out in the big, scary world. We're going to represent these subdivisions over here at this bookcase, and the different colored books and numbered signs are going to delineate the major divisions you want to know. The main development that determines whether or not a fetus can survive outside of the uterus and without its handy-dandy placenta is whether or not its lungs are ready to breathe. Enough surfactant needs to be produced so that the alveoli of those little lungs can stay open and allow for the adequate exchange of oxygen and carbon dioxide. This development occurs around the 37th week, which is why this is the cutoff between preterm and term babies. Because there are a lot of numbers and categories to remember, if you remember anything, remember this basic cutoff between preterm and term. To level up, learn the cutoffs between previable, preterm, term, and postterm. If a pregnancy is less than 24 weeks, then it's considered previable. This means that the fetus will not have developed enough to sustain life outside the womb even with assistance. This is a number that's constantly under debate due to advancements in neonatal resuscitation, but that's a topic for another time. Preterm is from 24 weeks and 0 days to 36 weeks and 6 days. This is the time frame during which the fetus is underdeveloped but still considered developed enough to be able to survive with the aid of medical interventions, although there can still be long-term complications. Term is any gestational age 37 weeks and higher. This is the sweet spot. And lastly, postterm is everything from 42 weeks and 0 days and above. This is usually the upper limit of weeks that most providers will let a pregnancy go, because at this gestational age and beyond, the risk of intrauterine fetal demise starts to outweigh the benefit of in utero development. Within these larger divisions are even more subdivisions. Only learn these if you have the previous definitions down. Within the preterm time period, there's another category called the late preterm, which is from 34 weeks and 0 days to 36 weeks and 6 days. In terms of subdivisions within the term time period, there are 3. Early term is 37 weeks and 0 days to 38 weeks and 6 days. Full term is 39 weeks and 0 days to 40 weeks and 6 days. Late term is 41 weeks and 0 days to 41 weeks and 6 days. It's only a week. Another way you may hear providers and patients refer to what stage a pregnancy is in is by trimester. Trimesters divide the total ideal gestational time, around 40 weeks, into 3 equal parts. But 40 doesn't divide by 3 evenly, so there's a little bit of a range on when the trimesters are divided up. Different providers also tend to use different cutoffs, but in general, the following are the most standard. The first trimester is from 0 to 14 weeks, the second trimester is from 14 weeks to 28 weeks, and the third trimester is anything above 28 weeks. I know, so far obstetrics has been a real number soup. Well, we're going to throw in one more set, but we promise, it's really important. Something you're going to hear thrown around the delivery room a lot is, what are the APGARs? The APGAR score is assigned to the newborn at 1 minute and 5 minutes after birth. It was created as a standardized way to evaluate infants in the immediate postpartum period. And no, APGAR isn't an acronym. It's someone's last name. The components of an APGAR are color, heart rate, reflexes, which means grimacing or pulling away, muscle tone, and respiration. Each component is assigned a score of 0, 1, or 2. A perfect score is a 10, and usually a score above 7 is considered good, though this is where the pediatricians usually take over. Fun fact, even though 10 is a perfect score, many providers never assign a baby a 10. Why? No idea. So if you hear 9 on L&D, that's considered pretty much perfect. A score is assessed at 1 minute and at 5 minutes. The 1 minute score is usually used to see if the baby needs resuscitation, and the 5 minute score is used to assess how well the baby has responded to any resuscitative measures. You may also know the APGAR backronym shown over here in this table. The APGAR score is not predictive, so you can't tell if the baby is going to show any neurological damage based on an APGAR. There are many more terms that will come up, but with these basics in hand, you should be ready to enter the crazy, unpredictable world of obstetrics. Who knew kindergarten could be so hard? Is it nap time yet?
That was a lot of information. I'm just gonna rest my head down for a little bit.
Delivery in room 33.
Well, so much for a nap. Baby calls.